Good morning and very welcome to our live surgery at the Swiss Biohealth Clinic in Switzerland. We are doing a surgery in our patient. We already had a live surgery patient some months ago. I'm going to show you the case. We already had implanted the palate socket on the right, number 3, with an immediate implant, balcony implant, but perfectly healed. We had done the cavitation surgery in the right upper, and we see everything has healed. It's just cortical bone, looks very nice, beautiful, and we did the cavitation in the lower as well. So today our plan will be to go to the left side. First we asked the patient if something improved, and she told us just that her right knee has completely improved. What is the stomach meridian, what runs over the right knee, so that fits perfectly, and her energy is way better than it was before. So she already had a very good outcome of the first part. We see there is plenty of bone for an immediate implant. We do not even have to do an internal lift. We just have to angulate the implant above 15 degrees, and we're going to ask the patient if she has got any problems on her shoulder, because that is the colon meridian, and she's telling us yes, she's got some problems on this meridian, and she told us it's on the right side, what is very interesting. So I believed that this is very well connected, because the meridian starting in the upper premolar area is the only meridian what is crossing the side and going to the other side. So the left upper is crossing to the right, and she's got problems on her right shoulder. So it will be very interesting. If we are lucky, she might already improve a little bit during the surgery. We're now going to do the anesthesia and prepare her for the surgery. We see as well that the right upper, number 3, has healed perfectly. The gum is even a lot more, 2 to 3 millimeters more than the neighboring teeth. So we, for the final crowns, we will have to remove a little bit of the gum to get it equal to or even to the other crowns and sides. So we never do a block, we always do the infiltration. So on the facial side and on the okay, now you could see here how much gum has grown right after the immediate implant. That's amazing. It's kind of a luxury problem. We've got 2 to 3 millimeters too much soft tissue, exactly the opposite what you always see or very often see in titanium, that you lose some gum. And we see here now this is the anesthetic on the oral side, and with that we are totally safe, and we will be able to do the cavitation surgery without causing any pain. You do not need a block, what is actually one of the causes for cavitation, because it's blocking the blood support for this area from the second premolar to the back in the lower. The vascularization comes from the inside, from the alveolaris inferior, and all other areas are vascularized from the outside, from the peripheral side. So in the upper, exactly the same. The injection into the facial side and onto the palate. We have to do that very slow because this is always a little bit of pain. I wouldn't say painful, but a little bit inconvenient for the patient, of course. So we should have about 2 ccm, 2 milliliters of the anesthesia per area we're going to treat. So I'm using the Articaine 40. So a few more drops to be on the safe side. And a little bit on the palate as well. So now we're cleaning the site from the bitter taste of the anesthesia. We're going to adjust a little bit my camera on my glasses so you will have the picture always in the center. Now we're switching for the sterile gloves and for the sterile setup after having done the anesthesia. In the background, the membranes which have been drawn just before the start of my surgery are prepared out of the spinning machine, that centrifuge. So we took, I think, 10 APIF membranes. It's important that you go in the 30-degree angle and that you as well angle the blade to the outside to avoid any injury of the lingual nerve, of course. You have to go back and forth and take care that you're definitely down to the bone. Then you switch for this shape. I'm always protecting the tongue with the little mirror, and then I go around the tooth on the oral side, on the lingual side, and then the same from the facial side to connect both cuts. Always go back and forth that you're sure you have cut down to the bone. Now I'm using my papilla elevator, what is kind of a beautiful, very small, very little raspatorium. And you see, since I've cut perfectly down to the bone, it goes very easy, very quick, very fast, very clean, absolutely minimal invasive. And you see, even with a cut like this, what was just 7 millimeters, if we go a little bit underneath the gum and especially to the lingual side, to be able later to place the membrane without having the need to expand the flap even more. We've got a beautiful beautiful view onto the side. It's exactly the same protocol when we remove a wisdom tooth. We never do a vertical cut. We never do a periost incision. That's all causing pain and swelling. So now we're already starting with the PSO saw. It's important that we start on the lingual side, parallel to the lingual wall. Not always we've got such a nice, beautiful, wide ridge. Sometimes it's smaller, and if you start on the facial side, and it could be that you have not got enough place to the lingual side, and if you do a second facial cut, so to avoid this, you always start on the lingual side about 2 to 5 millimeters away from the lingual wall. As well, you stay away from the neighboring tooth, the second molar, about 3 to 5 millimeters, to be able to go underneath the bone deep into the cavitation, where is quite often the need for. And then I'm connecting the cuts with the PSO. PSO is absolutely safe because it's just vibrating. It's not sharp. It's not rotating. There is no chance to damage the nerve. That is something we have borrowed from the spine surgery and brain surgery, and that is something what revolutionized the look at this. It's all fat underneath, so we're going to save that for the RRT test, autonomous response test, according to Dr. Klinghardt, to test if everything of the cavitation is gone. Now I'm changing for the other instrument we are using to clean the cavitation. First, I'm going to inject a few more drops directly into the cavitation because of the poor vascularization. That is why in medical field they call it ischemic osteonecrosis. So that bone not vascularized, it's quite often that the anesthesia is not strong enough. The patient could still feel something because there are still nerve fibers inside, so that is the reason why it makes totally sense to inject a few drops of anesthesia directly into the cavitation before you start. And now with the round instrument, the ball covered with diamonds, we're very softly, we're going inside the cavitation, mostly moving forward and backwards. Always parallel to the nerve. That is something not just the patient has to be patient, the dentist has to be patient as well. It takes some time, 5 to 10 minutes, and it makes no sense to do the RT test before you're not absolutely sure that you have cleaned everything. The RT should be the final check to be on the safe side. Otherwise, you would lose too much time. So it's important that you go underneath all the bone, because you could see that the extension of the cavitation is much bigger than the access to the cavitation. So we're still working on it, but you see the cavity, the hollow space is already quite big. And what we're removing here, this is, if you analyze, it's full of fat cyst, degenerative bone, and a lot of things are stored inside, like heavy metals, like aluminum, like Borrelia, Babesia, Bartonella, all the co-infections, Mycoplasma, many other things, glyphosate. And it wouldn't be so bad if there wouldn't be nerve fibers inside. But through the nerve fibers, the toxins and many other things, they could be transported, like we know from botulinus toxins or tetanus toxins, directly to the next ganglion or into the central nervous system, and cause neuralgia pain. That is why in Europe we call it NICO, what stands for neuralgia-inducing cavitational osteonecrosis, what was originally used from the American pathologist Professor Boku. But not all patients suffering from cavitations are suffering from neuralgia and facial pain. But in general, it's the heart meridian and the triple vomer, what is related to the arm, lower back, as well to the immune system, allergies, adrenal fatigue, all kinds of allergies. We see that mostly all the allergies are gone after cleaning the cavitations. Pressure on the chest, all kinds of heart problems like arrhythmia, or as well like cold hand and cold feet, blood circulation. So especially the cold hand and cold feet, they are mostly gone already during the cavitation. As well, the vision almost always improves during the cavitation surgery. That is why we have installed in every treatment room a vision chart on top of the ceiling, where the patient could test before and after. I think that's a quite objective test for the patient to understand if and what and how much has improved already during the surgery. So we see how far the cavitation goes underneath the bone. You could see that I clean back and forth, always parallel to the nerve, and always at the walls of the jawbone. So now I'm going to check with the thin suction if everything is clean, and we see that's all hard bone. It's very deep, but at the same time you see the tissue, everything is zero traumatized, so the surgery has to be minimal invasive, like this, with just a 7 millimeters cut. You should never use a Langenbeck hook. That's 1 second of Langenbeck means 2 days of swelling. Now we are doing the RT test. We are first starting with without the pole filter. Arm is strong, but this could be, but we have to test with the pole filter, and the arm is weak. So it's indicator muscle switch, what means the regulation is open. Now I'm having the test material of the cavitation inside my hand, and with a glass pencil I'm going to go into different areas and direction of the cavitation, and every time I'm checking with the arm what has to be strong without the pole filter. That's direct resonance, and in this case it was already completely clean. Mostly, in most of the cases, there is still some indicator muscle switch, so we know we have to clean a little bit more. So in this case we have been lucky. Now I had installed a cotton roll to avoid any saliva contaminating the cavitation. Now we are going to prepare the membranes already. They're beautiful, very thick, very stable, very big, and beautiful color, vanilla color. Some patients, when they are highly poisoned and intoxicated, the color is yellow, orange, or even brown. So those PF membranes are absolutely perfect. Now I'm using the ozone, what is killing all bacteria, fungi, and viruses through the O3, what falls apart into O2 and O1 atomic singlet oxygen. And we see the bleeding has come back, and it's very clean, very fresh, no fat droplets on top of the beautiful healthy blood. So now we're going to fill the cavitation with those PRF membranes. PF stands for platelet-rich in fibrin. So fibrin is a natural glue and could be exposed as well. So in this case it won't be exposed, of course, but in extraction sockets or in case of a perforation of the Schneiderian membrane, the membrane in the sinus, it's very important. And the PRF, if you compare it with the PRGF or the PRP, is a closed system, so it's absolutely safe. Nothing has to be added to the material. It's 100% just the patient's blood, what has coagulated through the speed and time of in the centrifuge. And it contains a lot of growth factors and even 1.2% of stem cells. So it's a beautiful, safe material. And we have opened quite often the cavitation areas some months later, and it showed that always the bone was completely closed again. Never place the bone back. What you took there, it would fall into the cavitation and could cause pain on top of the nerve. Now you see, since we have built a nice flap, it's easy to place the membrane, what is to be placed on top over the window we've built to clean the cavitation. We're using the Atramat dissolvable suture. What is a beautiful suture, very stable. It's bacteriostatic and quite strong, and I like it because it's transparent as well, so you could not even see the suture. First, we do an apical matrix suture, because in the lower the jawbone becomes wider, in the upper it becomes smaller, so there we won't need apical matrix suture, just in the lower to remove any tension from the tissue. We go back the same way. And then we just narrow the two flaps, and everything will be closed afterwards with the final suture on top. And now we are going for the suture on top. So you see that's a quite smooth and straightforward protocol what we have developed over the years, and it's absolutely atraumatic and minimal invasive. And with this suture, what is transparent, you will barely see at the end of the surgery where we have opened the site, and I try not to touch the soft tissue with my piezo. To have a perfect, nice and healthy situation. So erinnert ihr mich nachher daran, dass ich Neuraltherapie Tonsillen dann am Ende noch mache? Nachher noch herrichten. So. Then we're going to put some compression on top of the side to avoid any swelling. And on the other hand, since the membrane is a PRF membrane, platelet-rich fibrin, the fibrin is a natural glue, so that's perfectly closing the situation. And what we see now, that it's nearly impossible to see where the surgery was, and we see that is one of the most important criteria for any surgery. That is the flap, and you see if because of the epicamator suture I could move as much as I like the lip, there is no tension on the flap, so that is extremely important for perfect healing, and so you would never see a dehiscence. The flap would open, cause a complication. Okay. It was, the first was procaine with Traumeel, and this is some dexamethasone to stop the bad inflammation caused by giant cells. The good inflammation, what is creating bone and soft tissue growth, is based on leukocytes, lymphocytes, monocytes, and macrophages, and that is why we're using the PRF, because all those ingredients are inside the PRF membrane. So now we are switching, da muss ich ein bisschen die Spannung wegnehmen, for the upper. Alles okay bei dir? Macht Spaß? Okay, good. She's having fun. So now we're going to first remove the wisdom tooth, and you will see that there will be some cavitation in the back of this wisdom tooth. Yes, you can see there is not enough space for the wisdom tooth. It makes a lot of sense to remove this tooth. And so geht's? So that was the tooth. Quite strange roots, like the owner. So, nochmal sauber. So now we're going to open a few millimeters in this area and then connect to a little bit around the last molar. Ist die Kamera noch gut, die auf der Nase? Ja. Die Brille? Mhm. Schön in der Mitte ist. Mhm. So, if you would just remove the wisdom tooth and leave it like it is, like it's done in 99.9% of the cases, you would definitely cause later cavitation. And so now we are going to remove this bone around. If I would now have to do a sinus lift, I would collect this bone. Yes, you see I'm just breaking off the tuber. Stop. And look at this. Yeah, I think you can see that. It's all fat here, all fat cyst. Going to save that as well for the ROT test. Yeah. Okay. Of course, the septum of the wisdom tooth as well. And so we're going to have a quick look inside. And we can still see the fat cyst over here. Look at this. This is all fat, all soft. That's right in the back of the wisdom tooth. Yes, you see all fat cyst here. All soft. Kann man sehen, oder?
Ja.
So, now we're going to use the piezo. So. Ist gut soweit? Okay. Very good. So, the piezo, it's important that we protect the cheek with the mirror. The other thing is that by cleaning the cavitation, we are going to receive a nice blood support to the extraction site. Okay, now we see how far this good line going up. Good. Yeah, look at this. All the cavitation. I think we even have to go a little bit further with the piezo, and then we're going to have a test. It's the so you could see I'm now about 1.5 centimeters, 50 millimeters upwards to the cranial direction. So. So, yeah, we can now see, now it's all clear, wir bleiben. Und raus. Okay. And we're now going to test again. So I normally wouldn't need that again, but we do it just for halten. Okay, kurz herfahren und Polfilter drauf. Halten. Okay, we see the regulation is open. Okay, dann kann es wieder weg. And now I've collected some more material, so I can use it on this. Halten, 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 halten. Okay, what I could now demonstrate is, kann weg, is the following. Mal noch die große Einstellung lassen an die Regie. Warte, wir testen nochmal ganz kurz. So, we see. Okay, strong. Now if we knock onto this tooth, what is the root canal treated tooth to cause stress? We see there is absolutely zero, just nothing left. Yeah, here, nothing left. Now we get it back. Put the pole filter on top, and it has to be an indicator muscle change. Okay, that's it. Okay, so that shows the disturbance field of the root canal treated tooth. Now we're going to use the ozone. You see the extraction, it was 1 second, but cleaning the site and all the other things like ozone membrane is 20 minutes. But this is the most important part, to not to leave the patient with a later cavitation. So we do first suture and then the membrane, because it's easier to bisschen schließen. After the first suture, it's like a little bit more like a pocket where you could very nicely place the membrane inside. Kannst du mir mal noch das Periotest herlegen, weil wir nachher nach der Implantation, liegt schon da, das ist halt ja super. So, then I leave the suture beyond the sterile tissue, and now we are going to place some more membranes inside. Spiegel. Ja, okay, ein zweiter Spiegel. So. You see the membranes are very nice. And so now it's quite easy to place them inside. Okay. So then we always start on the palate side, because there the tissue is much more rigid, and so it's much easier in this direction than from the facial side to the palate. So, and the nice thing is that with this protocol we are already closing the gap. By 80 to 100%. Oben 1,0. And now you will see that this is a very positive side effect of the cavitation surgery. At the same time, we have removed the wisdom tooth, that the gap will be mostly filled, and the only thing what is exposed is the PRF membrane, what could be exposed because it's a fibrin membrane. So when you scratch your skin, so the first layer before the tissue grows back, this gray layer, that's fibrin. So the PRF membrane is allowed to be exposed. And so now we will have a look in a moment if we need more suture or if it's okay already. So it's completely safe against any foot could get stuck inside and compromise perfect healing. So let's have a look. Just going to. Das ist besser, gell? Okay. Yeah, we see it's already perfect, and this is. Yeah, we see it's very nice. Kann man sehen, gell? So it's mostly closed, and what is still, this little part what is still open is filled by the membranes, and was Dramamine and Procaine. Procaine is prolonging it's an anesthetic as well, but it's at the same time an antidote to the adrenaline, because it's vasodilatative. So now we're going to remove the Stoff 5, gell? 2,5. No? So, very good. Now a quick look onto the CT scan. So we're using the extension and the first. Okay. Yeah. We can see we have to do an internal sinus lift, but in this case we have got already 16 millimeters to the palate side. So with that we know we have to go, let's say, in the middle of the root in an angle of 15 to 20 degrees to the palate. Okay, dann kann ich auf die Kamera umschalten. Mal schön zurückstecken, den Sauger. Okay, now we see that was the tip of the root. I go about to the middle on an angle about 15 degrees. That is the right angle. Okay, we're going to have a look and we see it's perfect. Then we use the 2.5 pilot drill. The implant will be a one-piece implant, 4.6 by 14, oval shape. So you see this last laser mark is 40 millimeter, and this thicker part is 17. What is the level of the prosthetic level? So that is what should be exactly on the highest point of the neighboring papilla. So that is the bone class 2, 3.0. That would be the drill for the 3.8 millimeter implant. So, but we're going to go for the 4.6, also 1.1, 46, 14 oval. Oval shape. So. And yeah, we're going to use the counter. That is first the counter of the 3.8. It exactly fits to, that is exactly the upper part of the implant. So what you see is what you get. So you know exactly where the prosthetic plateau is going to be placed, and we see. If we would use the regular implant, it would be too narrow to the neighboring teeth. That is why I choose the oval shape. And I've used this to remove any torque from the cortical bone. So when we're talking about torque, it's in the cortical bone, the torque should be 0, because that is already quite poorly vascularized bone. We could get much more torque in the area of the tip.
the apex, but not, okay, in the area of the cortical bone. So it's totally wrong to install an implant with 40, 50, 60, 70, sometimes you hear up to 100 Newton centimeters. If the torque comes from the cortical bone, that's killing the bone. All tissue, if it's your brain, if it's your skin, if it's your bone, it's all about vascularization. That's priority number one. That is why we have created a so-called biological treatment, biological drilling protocol. Because if you put too much torque on any tissue or too much pressure on any tissue, you're going to lose the vascularization, therefore you're going to destroy the tissue. That's the so-called Mamoto's law, a Japanese researcher and scientist. So there is nothing against the strong torque on the upper part or on the apical part of the implant, but not in the area of the cortical bone. So we're adjusting the, maybe that's too long, we use the shorter one. So, the insertion tool is screwed onto the implant, and so that's totally safe. The torque is 35. Now we're going to, since we've got this beautiful thin tip and extremely aggressive thread, it's very easy to find exactly the same Okay, now we're going to switch for the ratchet because I want to feel what's going on. Now I might even exceed a little bit at 35 Newton centimeters, but I'm going to go 2 steps forward, 1 step back, something like this. But this stability comes from the apical part of the implant, not from the cortical bone. Und kannst gerade mal den Period-Test anmachen und schon mal kalibrieren. Also dieses Ding ganz fest draufstecken und dann schon mal drücken. So now we see that is the perfect position. Mal schließen, dass wir sehen. Ja. Okay, and open. Maybe we go 1.5 a turn further. What is, according to our inclination of 7 degrees, is 0.35 millimeters. So, okay. Gut, kannst ruhig ganz normal saugen. Now we're going to measure it with the, das muss runter, hier hinlegen. With the period test. Okay, we see minus 3.2, so that is extremely high already. So that is a nice proof that we could do immediate temporary, but as you could see, this torque, this extremely high torque, comes 100% from the apical part of the implant. That is why we've got such a nice aggressive thread. I mean, minus 3.2 would be as well already a good number for immediate, for a fully osseointegrated implant. So now we're going to fill the gaps with some more membranes. Okay. To avoid any thing go inside. So we see how huge this gap is, and but that will be all new bone. So the idea of biological implantology is to create extremely stable implant, but at the same time to have as much hollow spaces as possible, especially in the cortical area, because that will be new bone, lamellar bone, with perfect vascularization. So now we are going to do the preparation of the post of the implant. So our material is proven that you could, of course, you should use a new, a nice and smooth red ring diamond, no pressure, max water cool. But you are allowed. Kannst du mir nochmal ein ganz frisches Ei geben? Und auch den dicken Torpedo nochmal bitte in ganz neu. So, and please close. Okay, perfect. And again. So in this case we see there are quite old composite fillings on the neighboring tooth, so we are at least, even we see there's a little bit of decay over here, so we are going to connect the temporary to this tooth. You see here the decay. Okay, we see now how nice it was to choose an oval-shaped implant. You see how this perfectly fits in between. Then Formteil. Und dann kann man ein bisschen trocknen. Yeah. We're using the Luxatemp for the temporaries and made a splint, and with the membranes we are totally safe that nothing would be pressed into the gap between. Now to adjust it perfectly, and then it will be finished in the lab and cemented on top of the implant with Duralon and glued onto the first molar with acid etch technique and flow, and maybe even glued to the neighboring first premolar, number 12. So always with some sample to know when it's close. Mal zubeißen fest. So let the patient close and wait a minute. So we are now still since I started, less than 1 hour. So we see that's very quick and straightforward, smooth protocol. And open. So I've got a scaler in my hand to be able to remove the excess material in this area, and now we're very softly going to lift the temporary, and we're going to use an old scissors to cut off the excess material. So you rinse it with some cold water to reduce the polymerization. Okay, and please close. Und auf wieder. Und zubeißen, klappern 2-3 Mal. Und auf. Okay, and we see it's almost good. A little bit. We have to reduce the occlusion. Of course, there should be no contact, no side shift on the temporary, on the implant. Und mal zubeißen, 2-3 Mal klappern, klapp, klapp, klapp. Und auf. Und zubeißen und nach rechts und links reiben ein bisschen. Und auf. Yeah, let's see. Let's reduce this a little bit. Maybe this as well. Not to It's always easier if you do that first before it's finished in the lab. Nochmal zubeißen, klappern 2-3 Mal, ein bisschen reiben. Okay. So, I would say this is now perfect. I leave it for a few minutes there so it could harden in place. So, wir lassen es noch kurz drauf, den könnt ihr nachher dann runternehmen. Some Brocane and some Traumere. And okay. So, please move your right shoulder. Has there already changed something? Does it feel different? It is not, how much has it changed? Is it 80%, 60? 180. 180. So it's totally fine. No more tension, no more pain?
No.
Okay. Yeah. Yeah, you could see that is something we see very, very often, that the patients, they improve right away. And so that's very nice. Okay, that's it. Thank you very much to the team. And now it's your turn to fix the temporary. And we're going to forward with the course in about 10 minutes. Okay, thank you. So, 1 second. 1 second. Don't stop. Don't stop the movie. The tonsils. Holzspatel noch. We should always inject the tonsils during neural therapy, because that is the filter station of all the toxins from the teeth. And so makes totally sense to, so that is, you go about 1.5 centimeter to the side and very superficial, otherwise you would go through this and then it would just drop into the throat. And that was the upper bow of the tonsils. Then we go to the lower. That is right over here. And there you have to check that there is definitely, as you see how it's pushing upwards, that means we're very superficial, definitely not in blood vessel, because this artery goes directly, okay, sorry, goes directly to the brain. So that's, the lower bow is about 1.5 centimeter below the wisdom tooth area. So, okay, good. So, that's it. Now we are definitely done. Okay, perfect. Thank you.